Here we're going to do a cross-section right through here, and this is what it would look like, and it kind of points out exactly what we had just said. There is a groove in which sits the tibialis posterior tendon. There is a flattened area where the flexor hallucis longus rubs against the distal tibia. Now if we go ahead and look at an example, you can see here in this example in a coronal and transverse plane that we have a tibialis posterior tendon sitting in a very prominent groove.
So once again, this is a coronal sequence. You can see nicely several structures within the TFCC. The disc you see nicely. If you angle this off the hook of the hamate and the trapezium and take your coronal sequences from that point, you can nicely get your triangle fiber cartilage in just a couple cuts. In addition, you can see the homologue. It's a primarily triangular shaped structure. The ECU and the dorsal radial ulnar ligament you can also see in this structure. In another following cut, you can see the scapholunate and the lunato-triquetral ligaments. These are the most important structures.
Here is the normal looking posterior tibial tendon with the flexor digitorum longus. Here is one that fans out as it attaches, and that's a normal appearance. They often fan out as they attach to the navicular. And then here we have another one that's fanned out, but we have something else. This is a type 2 navicular with a cartilaginous synchondrosis, and these people are more prone to posterior tibial tendon dysfunction. So when you're looking at your x-ray or your radiograph, did it twice, you have to determine what type of os navicular you have, because the typical one you see is the oval one, just a little round.
Grammatically, what's happening is that transiently the ligament can be injured, as can the posterior acetabular rim, and then this can fall back into place, akin to a transient lateral patellar subluxation or dislocation event. And the importance of this in the orthopedic literature pointed out in this article is that even with just one of these transient subluxations, the risk of AVN or prevalence of AVN is actually 25%. And so they recommend that if you diagnose this on MRI, they may get a follow-up MRI to look for development.